So this is the statewide adult prevalence. Actually, we are much below the average of usually in India it is about 0.22 to 0.23 prevalence rate, but in Odisha it is only 0.13. Next. So you can skip this slide. Next. Next. Yes. So, what is the no. Previous slide, please. No. It's all right. Okay. So, what is the vision document for 2019 to 2024? We have discussed that by 2020 December we should achieve 90. It's all right. But again, there is a vision document by NACO for 2019 to 2024. That is, the goal is ending AIDS by 2030. So, what are the targets? The targets are 80% reduction in new HIV infection, baseline being 2010, and ensuring that 95% of those who are HIV positive in the country should know their status. 95% of those who have known their status should be on treatment, that means should be on antiretroviral treatment. And out of those who are on treatment, 95% of those should have durable viral load suppression. So previously we have seen that it was a 90 target up to December 2020. But now in this vision document, it has been 95. This is the target, 95% up to 2024. If we can achieve this, then only this ending of AIDS by 2030 will be possible. Next. So what is the fast track target? 90 that we have already discussed. But what is the scenario vis-a-vis global average? If you see percentage of PLHV hour of their HIV status, global average is, our target is 90%. But till now we have achieved 79%. Global average is also 79%. It is of course 2018 global statistics, but our statistics is up to 2019. It is 79%. And I hope it has been increased to some extent, but not up to desired extent because of this current pandemic. So out of those first 90, about 82% are receiving ARC in India, but globally it is 78%. And out of second 90, our viral suppression is about amongst 78 HIV, whereas this global average is 86%. Here we are a bit behind. It is because of the viral load testing facilities in all the centers. Viral load facility is not there, and anyway, now the viral load facility means viral load machine is not in all the centers. The NACO has given to some ART centers this viral load machine, and with some ART centers there has been a MOU with one of the laboratories from Mumbai, and we are collecting blood from all the centers here in Odisha, and we are sending to that laboratory, and they are sending it. Therefore, almost in entire country, this is the scenario. Different laboratories have been designated, and they have been signed with a memorandum of understanding with NACO. So therefore, I hope this will also increase very soon. Yes. So now, what are the areas of consideration? This new HIV infection, timely contacting and releasing the budget by NGO or CBO targeted intervention and link worker scheme, because these NGO and CBOs are also link workers. They have a very vital role in bringing the new cases. And there should be multi-sectoral response involving education, women and child development, social justice and empowerment, labor, all these departments, they should be also included in this program. And HIV testing, actually HIV testing has suffered a little bit, but we should test as much as possible, and testing enough and testing right. And then treatment, this ICTC ART linkage, there should be no gaps, there should be no loss of patients in between ICTC to ART center, and ART initiation should be very quickly done. And we must see in the ART center that retention is very good, because the ART retention is equally important, and also ART adherence. The PLHIV who is taking antiretroviral treatment, they should adhere, at least their adherence should be more than 95%, so that their viral suppression can achieve. Okay. So, what is the rationale of HCTS guideline? HCTS means HIV counseling and testing services. That early detection should be done and immediately linked to the ART. Current scenario is about 70% linked is there, but 2020 goal is 90%, and we have seen that 78% has already has been achieved, and we hope it will soon be achieved. Next slide, please. So I have to be a bit hurry. So what are the new abbreviations in HCTS guidelines? CBS is coming to the screen. HCTS, I have already told, HIV counseling and testing services. And 3 I's, that is intensified case finding, isoniazid preventive therapy, infection control. This intensified case finding means to detect the TB cases in the ART setup, also in the ICT setup, and isoniazid preventive therapy is given to those PLHIV who are not under TB treatment, because the HIV people are very prone to contract the TB infection. So if we give them isoniazid 300 milligram to the adults once daily for 6 months, it has been seen that they may not contract this TB infection. So because it has started since last 2 years or 3 years, so it will be difficult to predict now what will be the result, but now we are following it. So this pulse also has started PLHIV ART linkage system, and we should know that the consent, confidentiality, counseling, correct testing, connection, these are very important things for the program. Next. So in HCTS, there are screening facilities and confirmatory facilities. Next. So screening facilities means where only one test is being done, whether FICTC, PPP more ICTC, in PI targeted interventions, those are the, in OPD, IPD, or emergency wards, even in our labor rooms, all those are screening facilities. So if they find it reactive, then they must send to the confirmatory facility, that is standalone ICTC, where this will be done, the test will be done to 3 rapid kit tests, and then it will, if it is confirmed, they will be starting ART. So we'll go to next slide. So to promote the early detection and co-infection, that is mainly whether there is TB or not, and whether when there is TB with HIV, we call it a co-infection. But we should equally look for the sexual transmitted infection and reproductive tract infection, and other co-infections is there. But when there is co-infection, it is very important for us at the ART center, because we have to start potential prophylactic therapy as well as daily anti-tubercular therapy. Then standard operating procedures for all councils and laboratory technicians, they should have screening and confirmatory facilities, what to do, what not to do, and they should be able to carry out these additional responsibilities with ease. And new sections are HIV-TB collaborative activities, linkages, supply chain management, and IC activities. All these things are being done nowadays also. Right. So these are the priority populations to whom we should test. Number one is infants and children, because all newborn babies of HIV positive mothers should be tested. So also, having any two pertinent signs in a child, particularly pneumonia or sepsis or oral thrush, or the first and oral thrush for more than 3 months. If any children is having these signs, they should be also exposed for HIV screening. They should be screened for HIV test. Then adolescents from 10 to 19 years of old, all adolescents should be tested because there are risk behavior and also there might be STI in the RTI. Therefore, this should, and all pregnant and breastfeeding women that we all know, then all STI and RTI attendees and patients, they should be tested. So next. So occupational exposure. Any healthcare worker, if they are accidentally exposed to any infected materials or anything, they should be also tested. Checking. Previous slide. Yes. In emergency setting like casualty or suppose any DIL case that is direct in labor case, it comes to the labor room, all those they should be also tested. And patient is collagen, it is not prevalent in our area, so we can ignore it. All tuberculosis patients should be tested. All sexual partners or spouses of the people living with HIV. All high risk group, as we have told, female sex worker, men having sex with men, and IDU. Also bridge populations like long distance truck drivers and migrant laborers. All prison inmates, they should be also tested. And the persons who have undergone sexual assault, particularly in case of rape and other things, other sexual assault. Yes. So next, 17, it has been now made. This legislation has been passed in the parliament. Also, it has been passed in our state also. So, elements of mother to child transmission that I have talked to you in the previously. So, this 2020 fast track target is antenatal care coverage should be more than 95%. Coverage of HIV testing of pregnant women should be more than 95%. And antiretroviral treatment coverage of HIV positive pregnant women should be more than 90%, so that we can eliminate the mother from transmitting the HIV virus or syphilis virus to the child. Next. So, I will ignore this step. Next. So, what are the essential packages in PPTCT services? Actually, we should offer routinely HIV counseling and testing with opt-out option, but nowadays we don't give much stress on opt-out to our option. We always offer them HIV counseling and testing to the pregnant mother. Ensure involvement of spouse and family members. Provide ART to the HIV positive pregnant and breastfeeding women. At first stage of whether it is in the first trimester or it is in second trimester, it is third trimester, or after delivery during breastfeeding, whenever it is found that she has not been tested for HIV, we should offer the HIV test and provide, if becomes positive, provide ART to the lady. Promote institutional deliveries of positive pregnant women and provision of care of STI, RTI, TB and other opportunistic infections. So nutritional counseling and psychosocial support to them is highly necessary. An antiretroviral prophylaxis in form of nevirapine syrup should be given to the baby delivered from a pregnant positive pregnant lady, and follow-up of the HIV exposed infant with cotamento prophylaxis therapy, then early infant diagnosis. Because previously what was happening at 18 months, the rapid test was being done, and if it becomes positive, then we were giving antiretroviral treatment. But now it is possible to get the diagnosis through DNA PCR test in between 6 months and 6 weeks to 6 months. So if the child becomes positive, we will go for the second DBS test, and if the child becomes positive in both the tests, we will go for antiretroviral treatment. Even if the child is 1 year old or 14 months old or 15 months old, we will give the ART, antiretroviral treatment, to the child. Next. So I will very quickly go for this child, because we know mother-to-child transmission occurs only during pregnancy, labor and delivery, and breastfeeding. So the major factor that increases the risk of mother-to-child transmission is amount of high viral load. High viral load in the mother's blood. Next. Next. Hello.
Yes, sir.
Yes. So actually what happens, what is the risk of mother-to-child transmission in absence of an intervention? During pregnancy, it is about 5 to 10%. During labor and delivery, it is about 10 to 15%. During breastfeeding, it is about 5 to 20%. Overall, without breastfeeding, 15 to 25%. And overall, with breastfeeding up to 6 months is 20 to 35%. And overall, with breastfeeding for 18 to 24 months is about 30 to 45%. When there was no intervention. But now, after this multi-drug treatment that with TLE to the pregnant ladies, this has been reduced to 0 to 2%. So there is nothing to be panicked that why we should not breastfeed the child. Because even previously it was being told that if a child is negative, don't breastfeed after 6 months. But if a child is positive, you can breastfeed up to 24 months. But now it is also told that even if a child is negative, we can breastfeed the child up to 24 weeks. There will be no problem since mother is getting antiretroviral treatment. Next. So these are next slide, please. Yes. So interventions during pregnancy, we should observe for signs and symptoms of HIV infection. That is what I told, that the pneumonia, sepsis, and oral cough for more than 3 months. So all HIV exposed should receive cotamento at 6 weeks of age. Up to 6 weeks, we should give nevirapine therapy. Then we should give this cotamento therapy and follow standard immunization schedule. So what I have told, this, if some baby becomes EID positive, if some baby becomes EID positive, for these infants, exclusive breastfeeding is to be done till 6 months, then it can be continued up to 24 months. And in case of negative also, it can be continued up to 24 months. So HIV testing needs to be done again at 6 weeks for cessation of after cessation of breastfeeding according to EID protocol. Next. So it's a proven tool. Immunization is a proven tool for control and eradication of infectious diseases and most cost-effective measure to reduce the childhood morbidity and mortality. You know. So universal immunization program, which is continuing in India, they have no formal guidelines for CLHIV, that is child living with HIV. But Indian Association of Pediatricians, they have established guidelines for vaccinated children with HIV infection. Even CDC, SCIP, and WHO, they have recommended immunization guidelines for HIV infected children. Right. Immunization is generally safe and beneficial for children living with HIV. Although HIV-induced immune suppression reduces the benefit compared with that of HIV uninfected children. HIV children may benefit little bit less, but it is always advised that the HIV children to HIV positive children should be immunized like that of uninfected children. The child has rapidly progressing, unless the child has rapidly progressing HIV-related disease, usual routine vaccination should be offered according to age. Our only thing is that we can avoid live vaccines if there is severe immunosuppression. But for all practical circumstances in our situation, encourage all vaccines in infancy unless patient is severe or in the late stage of the disease. Encourage optional vaccines like pneumococcal and measles. Right. So what are the support required from you as well as from others? Single window access to HIV testing along with other antenatal testing. That means when the antenatal case is coming for testing of the hemoglobin, sugar, urine, hepatitis, syphilis, there also HIV testing should be done. Whole blood fingerprint test for community-based HIV screening of all pregnant women, which has already been started in our state in the GHND program, and training of ANM and ASA for HIV screening at villages and municipalities, which is being carried out now, and incentivize the referral linkages of positive pregnant women to ARPC may be funded by states. So this is a proposal which has been given and not yet done. Next. Establishment of antiretroviral therapy. Now the Board of Governors in supervision of Medical Council of India has issued an amendment of Gazette notification dated 25th June 2019 that ART centers should be established in all medical colleges which are functional for more than 4 years. And for medical colleges which do not have ART centers, NACO is to provide drugs and technical support, while HR and infrastructure, human resources and infrastructure will be supported by the institute. For medical colleges where ART center is already functional, with NACO support, medical colleges may take over the HR and the recurring cost of the components of the ART center in a phased manner. For medical colleges, private medical colleges, where ART center is already functional in PPP mode, it is proposed to continue the same approach. Yes. So I thank you all the participants and all the organizers for giving me this opportunity to speak on this World AIDS Day regarding the aim, goals, and the achievements which have been done. I hope this will come up, though not more, but a little bit help to you. I again thank you all for participating in this talk. Thank you.
Thank you, sir, for your insightful talk. Really, this is a wonderful session. Now I request to our students or participants, if anybody having any doubt, you can ask. And also you can write in the chat box. If any participant having any doubt, please write.
I hope there is no question because the time has gone beyond the
No, sir. You are explained very well. So that's why I think all the students have to well understood.
Okay. Thank you.
Thank you, sir. Now we go for showing some posters that are made by our GNM third year students on this occasion of the AIDS Day.
हेलो हाँ आप किधर गए
Finally, we call this program an end. First of all, I would like to propose hearty thanks to our esteemed speaker, Dr. Vijay Kumar Behera, Medical Officer of ART Plus Center, SCB Medical College, Cuttack, Odisha, for this insightful and enlightening information about HIV/AIDS and elimination of mother-to-child transmission of HIV/AIDS during this COVID-19, and hope it will help out our students a lot in managing the HIV/AIDS patient and help in elimination of the mother-to-child transmission of HIV/AIDS during this COVID-19. So from that also, even we must use this moment to highlight our success and address the gaps in the treatment, prevention, and care paradigm to demonstrate the strength of our residents. Next, I would like to give tons of heartfelt thanks to Dr. Professor Prabhati Tripathi, Dean, for constantly encouraging us for these kinds of sensitive awareness program for our students and faculty. Hope definitely it will create a sense. Next, I would like to give heartfelt thanks to Dr. Professor Sasmita Das, Associate Dean, for constantly encouraging us and giving their valuable time for this program to success. I would like to give heartfelt thanks to Professor Tapati Saha, Additional Dean and HOD of Department of Community Health Nursing, for giving constant support for our department. Now, I would like to express my gratitude to all the participants for their active participation and kind attention. Now, I would like to thank to our students who participate in the poster preparation. I extend my thanks to all the faculties, Department of Community Health Nursing, for immense support, hard work for making this program grand success. Thank you so much. Have a good day. Thank you, sir, madam.